Hi, everybody, and welcome to Neuroscientists Talk Shop, UTSA's neuroscience research podcast. Today is December 8th, 2025. It's a Monday. It's not our usual podcast day, but that's because today is special. It's the day of our annual UTSA Neuroscience Distinguished Public Lecture, and we have a special guest who will be giving a public address this evening, which is sponsored by the UTSA Brain Health Consortium. And we're happy to have with us Dr. Matthew Goodwin, the professor and associate chair of research at the Department of Public Health and Health Sciences at Northeastern University, and he is jointly appointed at the Khouri College of Computer Sciences at the same place. And he does applied research. He works with children and adults on the autistic spectrum. Hi.
Hi. Thank you for having me.
I'm so glad you're here, actually.
Thank you.
Also with us is Leslie Neeley, who is director of the Child and Adolescent Policy Research Institute and also associate director of the Brain Health Consortium here at UTSA. And Leslie should have probably been on podcast by now, but we're so happy to have we're so happy to have you here. Welcome.
Thanks for having me.
And I'm Charlie Wilson. So Matthew and Leslie, I sort of hope both of you will answer this or participate in answering it somehow. We're going to be talking today about advances in technology for behavioral assessment and intervention in autism. But before we get started with that, I wonder if you would spend just a minute telling us about autism. It's a word that gets used so much. I think maybe overused, but I can't say that for sure. But it seems like that. I hear lots of very high-functioning people say that they're autistic in some way or on the spectrum somehow, and I don't assess that. I don't have any technological means of assessing that, and but maybe they're just socially awkward, and I have doubts. But could you just tell us what autism means from you, from a practical perspective, dealing with people who are actually diagnosed with autism?
Sure. Well, I could start with the actual diagnostic criteria. So, to be diagnosed with autism, you have to show signs early on, so in childhood, in two domains. The first is social and communication needs. So this could look like reduced eye contact as one of the diagnostic criteria in socialization. It could look like individuals who develop speech later, and it could be all the way to the other end of the spectrum where they never develop speech. And then the second one is engagement in repetitive and restrictive behaviors and interests. This could look like an individual who engages in hand flapping, for example. That is one of the clients that I might see, somebody who doesn't speak and communicates through behavior, all the way up to an individual who has difficulties with transitions, change, knowing what's going to happen at the doctor, but is able to communicate. So it's really one of the characteristics of it is it's a spectrum. So who comes through my doors? It could be the person who can speak and is trying to learn some flexibility and some ways that they could be more flexible with our very changing world, all the way down to an individual who's trying to learn how to communicate via pictures or an iPad.
Yeah, and secondary features, often sensory sensitivities, either being overwhelmed or underwhelmed. Anxiety, stress-related, has started to get some more attention around emotion regulation. I think what's kind of interesting for people to note, if they're not already aware, we don't make a diagnosis unless it's creating problems with daily functioning. Okay. So this is not so much an essentialism question as it is, are services required for someone to have better quality living? Second, we don't have a biomarker for autism, so it's defined behaviorally, and there's an enormous amount of variability to reach the same, might call it a clinical endophenotype. We sort of agree that it's somewhere along the spectrum or under the umbrella, but you can have huge individual differences along that continuum.
So maybe that's a nice entry point for thinking about technology, because you probably have a little bit of trouble with metrics along that big spectrum. How do I place somebody on the autistic spectrum? What measurements do I take? So you don't have a biomarker, but you have behavioral markers.
Right.
And so is there a way to quantify that kind of thing?
Yeah, there's been quite a bit of advancements in different ways to measure those individual characteristics that can contribute to an autism diagnosis. So things like eye tracking software or AI for the identification of the repetitive behaviors. Ultimately, though, it's a human clinician who has to make that diagnosis. And that is specifically because of what Matthew said, in that it has to impact daily functioning. That is one of those core pieces. And so if you are maybe a little bit socially awkward, and I think maybe a lot of people have recently heard of autism, it's in the news, it's getting a lot of focus at a state, federal level, just socially, so that we're becoming more aware of just the diagnosis itself. But just having some of those characteristics is not enough for that autism diagnosis.
Yeah, and so we have a rate of 1 in 31. That's the present CDC estimate based on the last.
Pretty high.
Yeah, it was 1 in 10, 1 in 110 when I started my doc program. And so that was already pretty high. I think it was 1 in 250, just the...
Incidence is really going up, or is there some flexibility?
The devil's in the details. So you just said incidence. Right. We have prevalence data. We don't have incidence data. So this is one of the problems. It's all cross-sectional and the criteria has changed. People have studied this and written about this. We're diagnosing earlier. We've broadened criteria when we brought Asperger's in. It used to be a spectrum that considered Down syndrome and Rett's, in addition to PDD-NOS, which is a pervasive developmental disorder not otherwise specified, can also be on the spectrum.
And PDD, normal. So there's a whole host of things that got combined into one diagnostic.
The American Academy of Pediatrics started to say mandatory screening and well visits by age 2. Early intervention started to demonstrate that it was having an impact. We were using a lot of data based on school records. Families who live closer to kind of urban settings and academic services are overrepresented. So there was a lot of data that could suggest that we were inflating these. Better Awareness, Autism Speaks kind of came online, and other advocacy groups that were bringing this more into the population's consciousness. Even, best you can with epidemiological data, which is primarily correlational, not causal, we're still seeing increase even if you take more conservative criteria and you account for those different factors. Yeah. I think it's happening more in the world, and we're especially seeing now, based on the last CDC census, the first time they gave a designation of profound autism.
Right.
So these are individuals with minimal or no verbal ability, IQ at or below 50, and require 24/7 care to maintain safety. And it's the first time we got a nationally representative sample who included that as a designation, and they estimated that 2.7% of 27%. So 1 in 31 is 2.7% of the world population. You could estimate that at 78 million people worldwide. And 2.7% met criteria for profound. So that's 21 million of the 78 million. That has been largely unrecognized in the field, the vast number of individuals who are more severely impacted and have higher support needs.
And there's a lot of reason for that. I mean, partially some of this awareness is being spread by individuals who are able to speak for themselves. The individuals I serve, the individuals who have profound autism, their families are living day to day. They don't have the ability to take their kid to the grocery store. Their houses are often, arranged for the safety of that child and the safety of the individual or the family. And so they themselves don't have the ability to share their story. And so now there's been actually quite a bit of movement in some grassroots families getting together whose children are older to start to bring visibility to that. And so that was part of that profound autism categorization, which is huge, because now we're starting to really share what's happening with these families and their need for a very, I don't want to say heavy, but, substantial support, very different from, say, somebody who is able to speak. And I think the example I gave earlier was they just need a little bit of help in learning how to be more flexible.
They're not out in the community as much as individuals with lower support needs.
That's right.
they're at home, and there's usually a parent who is not working, who is at home with them. So we're not seeing them. So they're not getting socialized, but they're also not being recognized by the community. I think this is a really important data point, because they're who we understand the least, and they're who we need to support the most, and marshaling resources to systematically determine, what do we know, what do we not know, what do we need, and what's the method to determine that, so that we can understand better what are the risk factors, what are the phenomenology, the manifestation when it's there, and then, should we lump or should we split? Are they all very similar to each other, or is there heterogeneity and individual differences within that spectrum of autism? These are all open questions. And interestingly, if we're going to make a segue to the technology, we have a vast literature in autism now than we did, say, 50 years ago. But if you look at journals and you read in the methods section participant demographics that describe features of the people under study, you will most often, in most published studies, see that it's verbally fluent, typical or superior IQ, and good emotion regulation. They're a convenience sample to the researcher. Most research is based in labs or clinics where you have highly trained people to do data collection or to administer therapy. If you have a sensory sensitivity, if you have intellectual challenges, if you have executive function problems, if you have emotion regulation problems, if you have a difficult time understanding instructions or the nonverbal cues of the people that you're with, this is a potentially threatening environment. And if part of this condition is sensitivity and uncertainty to other people, coming to the lab is a very difficult thing to do. So we have underrepresentation based on our methods. And so Leslie, myself, and others in the field have been increasingly working with computer scientists and engineers where we might be able to take the lab to people instead of bring people to the lab. And so starting to think about tools, technologies, and methods to instrument places and people. There are two tread fields within computer science called ubiquitous computing and wearable computing that are kind of starting to merge with the behavioral and health sciences to think about real-world data collection. And this opens up a whole plethora of cameras, microphones, embedded sensors, wearable sensors, trying to capture biology and behavior in real-world naturalistic settings where we have ecological validity, basically taking the lab to the world. We think is a way to accommodate more objective measures in real-world settings to figure out what data matters to quality living.
So I work in the field related to Parkinson's disease, and there's a move for Parkinson's patients to instrument them so that their movement disorder can, because movement disorders are often altered by being in the test setting. So get it all home and have them wearing it. But a lot of that is like talking to somebody on the computer, interacting with some fairly elaborate diagnostic. Now, I suppose all of this has to be done in a way that doesn't actually get noticed by them.
Yeah. Oh, go ahead.
Well, it's a good point. So many of the individuals, so what I'll be speaking about later today and where a lot of the work is focused is in that more profound designation of autism. They can't describe to me what their experience is. So I have to talk to their parents who will say, I think I know what's going on, but I'm also uncertain why they engage in the behaviors that they do. And what is the precursor or trigger that elicits that behavior? What is the state of the individual that puts them at a higher probability of engaging in a concerning behavior, what intervention is the most effective, parents will have a very difficult time articulating that. So that's one of the reasons why we want to go measure it.
Yeah. That's a key question for them, right? How do I know when a meltdown is about to happen?
Yeah, so let's get very concrete. So the things that both Leslie and I are interested in are that restricted and repetitive behavior around motor mannerisms. So things like flapping, rocking, finger flicking, we see it at high rates that tend to correlate more with that profound designation. There have been many different theories about why people engage in those behaviors, of which we don't really have a consensus. And for a given individual may engage in the same behavior for an entirely different person than another child who engages in the same behavior. Whether it's to escape or avoid, whether it's to be an alternative form of communication, whether it's proprioceptive, it's how you feel your body in space and time, whether it's affective, it's communicating that you might be excited about something or anxious about something, whether it's soothing, arousal, reducing or increasing. These are all been posited theories, and there are others. It could be sensory, it could be some interaction between what I am experiencing when I can move my own limbs relative to something else in the environment, or it may dampen sensory input because I can just focus on this one repeated thing that I am engaged in. These are all valid theories of which maybe only a subset operate for a given individual. So we can't make an assumption about the behavior until we've tested those alternatives. We're also interested in aggression to self, other, or property. And, are these, I don't think either of us think these are willfully bad behaviors to get rewarded off causing harm. I think both of us think of this more of stress and coping, fight or flight, in the absence of a rich coping repertoire.
Mm-hmm. And communication, right? There's a communicative function for a lot of these kids as well. I give the example of, I have 4 kids, and one of the estimations is 20% of children engage in head-banging behaviors, just neurotypical as they develop. And I had 2 of them. 2 of my kids engaged in head-banging. And this also happens with the autistic population. What's different is my kids were able to develop spoken language. So they're now able to communicate. I'm frustrated. I'm upset. I want something to go away. Individuals who have communication needs or delays, they're not able to communicate. They start to get that environmental interaction. Mom comes, tries to distract them, right? It's scary. I will tell you, one of my kids really engaged in pretty intense head banging, but I knew what could happen. So we tried not to provide any sort of, interaction during that because I didn't want it to gain a communicative function. So they learn, I bang my head, Mom will give me, a snack or water, try to distract me. So then it becomes their form of communication. And it can get worse over time because then Mom says, hey, I'm going to really try not to reinforce that. Well, then they try harder. Mom says, okay, I have to intervene at this point. And all what the kid has learned is now I have to hit really hard, or I have to hit a lot. And so it starts to become, you can get really complicated where you get adults who have a long learning history. They have a lot of different topographies of behavior that they've tried out over the years. And I will have individuals who come to me who we start intervention. And as we start the assessment procedure, I see every single topography because everything starts, they're going to try everything. And that's really important information for me because I know, okay, here's the sequence of behaviors that might happen. Here's how we identify our safety protocols, but also here's all of the things I need to prepare our parents for, clinicians for, and that we have to assess and make sure we know what they're trying to tell us.
So if you move a lab into somebody's home where a child like this lives, you're basically seeing everything that happens in that home. Parents have any hesitation about instrumenting their home like that?
I will tell you, my families do not. I don't know that I can communicate. I think people have to see it to really understand how desperate these families are. I have never had any concerns from any families. They I will tell them, here's what we're doing. And I am really careful because I want to understand I am a clinician, so I can treat. So I don't want them to think this is a gate for them. They have to agree so that they can gain treatment from me. So I'll always have a lot of options. Most of the time they are like, absolutely, whatever you need to do, we just need help. They've seen physicians, they've seen teachers, they've seen other clinicians, and their case is not one that responds to that lower level treatment. And so they are like, whatever you need to do at that point. And I don't know if you've had
this has been my experience too. Most families say, I'm glad someone is paying attention and someone can see how difficult we have it. And so that maybe we can get the help that we need. I mean, go on YouTube, you'll see plenty of videos that parents have posted of their child with autism engaging in difficult to watch behavior, because I think they want more attention brought to this matter.
So before it's too late, I'd like to start talking about the tech.
Yeah.
So what's the state of the art of doing that stuff right now, and where's it going to go?
So there are a lot of people who are starting to do work with cameras and computer vision, with microphones and speech analytics, with inertial measurement units, accelerometry, gyroscopes for kinematics, and then wearable biosensing. So these are collecting peripheral autonomic nervous system metrics like cardiovascular, electrodermal, and skin temperature. I would say that's kind of a suite, and I'll add mobile event marking or kind of ecological momentary assessment, apps on phones that let parents make subjective ratings.
They can annotate what's going on.
Correct.
Exactly, in the moment, which is really important.
And then you get volumes of data from all of those different, there's some tech challenges here. So you have different modalities, sampling at different frequencies. They're passively collected. And so obviously the parental reports are active, but the cameras, microphones, and wearables are collecting data all the time. So you get volumes of data where you've got important signals embedded in potentially a lot of noise. And so it's too much data to visually inspect and manually correct and annotate. And so you're starting to see, I think, increasingly more people feeding these to large language models or to other kind of AI-based batch processing or signal processing of data. And then,
does this stuff get directly streamed to you, or does it get stored locally and read later?
So you can do offline or online analysis. This is the frontier. The devil's in the details. So what are you trying to measure? Where are you measuring? What is your ground truth? How much abstraction? What is the right way to parameterize it? What metadata is demonstrated to correlate with something that you know, or predict an event, or explain variance in an outcome? Depending on some people are using this as a screener, trying more tech methods to do screening. Some are trying to use it during diagnostics. Some are using it to try to phenotype, show individual differences across people with the same diagnostic label. Others are using it in functional analysis of behavior, which Leslie can speak to better than me. Some are using it as prediction of an outcome, like developmental course, or response to intervention. So it sort of depends, which modality, what setting, which segment of the population, what behavior of clinical interest will somehow dictate the landscape of.
It leaves a lot of choices for you about what to.
Oh yeah, a little overwhelming, the choices, I would say, right? Like, how do you spend? We were talking about that this morning. Yeah. There's a lot that needs to be done to push the field forward, and just the many different technological tools we have all need to be tested, and every single one has to be tested on all of these other. Are we trying to measure speech? Are we trying to measure social interactions, or are we trying to measure these behavioral responses? Those ones that we were talking about of concern, like aggression, self or others, or poverty. So it just is. It's a huge, wide open field. And I don't know how many people are really, we were talking a little bit about kind of a handful of researchers in our area. But we need more. If you're interested, you can join. We take all the researchers we can get, but it's really wide open. I think.
I would like throw a gauntlet. So you heard it first on this podcast.
Oh, yeah.
I think we need a consensus. We need interdisciplinary roundtables about what are the behaviors of concern, what are the modalities by which you can measure, what are the ways that we're gonna process data, what are the parameters that we're gonna use that are clinically meaningful, and then start to demonstrate. So that different people around the world working with the same population have comparable data sets analyzed in a comparable way, that we can start to compare and contrast different methods or utility of some of these metrics.
So a few years ago, I think somebody would have said, maybe people still say this, well, you should let the data decide. Just put the whole thing in a big, what's the...
I would say junk in, junk out, and I would say because we don't have a biomarker for autism, you've got apples and oranges and kumquats and pomegranates, and there's great variety there. And, interestingly, from just a general methodological standpoint, we have a rich class of statistics that are frequentist, probabilistic, assume central tendencies, and so they're nomothetic. Right, it's looking at the average and making a statement about what's shared. But when you have a highly heterogeneous condition of unknown etiologies, there's probably more than one, and great individual differences, and clinically, we really are asking more of an idiographic question where the individual serves as their own control.
I love that you said that, because that's single case research methodology, which I will speak about at our department meeting when I do my talk. But this is exactly where I hope, the field will go, and the people treating this population or analyzing, the behaviors, or it really is on an individual level, because there is, I think there's even that saying, right? You met one person with autism, one person with autism. It's just not, it's so difficult to generalize, which is why I love my job, because if you come into my clinic, I've never seen a case like yours. This is going to be an exciting, almost detective life. I need to understand you. I need to understand your contacts. Now there's a whole, so far 8 pages worth of variables I have to consider. But I know that I can get to know you, get to know what your needs are, get to know where you live, what environments you live in, and design an intervention, and then test it with that single case methodology on a day-to-day basis to see which one you respond to, which one you like better, which one your caregivers like better, which one is better for home environment, school environment. I don't know any other science that is like that can make that level of individualization.
And in fact, most of us aim for some kind of phenotypic categorization.
Yeah.
And when people say autism isn't just one thing, the first thing I think of as a biologist is, it's 12 things. And we could type A and we could have type B and type C. But is that not true?
This is how the Diagnostic and Statistical Manual is set up, right? It's a taxonomy. International classification for disease is set up. That's what they use in the EU primarily. Same way. I don't remember exactly what it is, but so you have 2 main criteria for autism, and you have these 2 associated features. But the way that this gets assessed is that you can have several different options that meet criteria. At one point I knew it, but if you calculate all the different permutations, there's something like over 300 different individual configurations to give rise to the same single label. Yeah. So that tells you right there that we're describing things. Yeah. We're not explaining things. Yeah. And most of them are qualitative impairments in ... It's not quantitative. We're not measuring in the way that I think filling out a survey, doing, the developmental histories, you could do a 3-hour interview with a family. There's a core set of items that you're filling out. We have the autism diagnostic instrument is going to be like a 45-minute standardized tools in a standardized setting. There's standardized ratings. There's an algorithm. You do a little addition and subtraction, and you convert a code. It feels quantitative, but we're not actually measuring anything. You're really using developmental history and subjective appraisals. And so what coming back to what you were saying about the idiographic, I'm not a clinician, but I have very applied, I want to instrument people like Leslie to be able to have more of an evidence base for the decisions that she makes, and know what's working for whom. So it's not trial and error for every new family. It doesn't come with a manual. You know, some families get very lucky, and some will be searching for a useful intervention and never actually achieve one. Find the right fit. All children can make gains, but you have to intervene on the right thing at the right time in a consistent way. So I'm not convinced that autism is an N of one universe, that they're all completely individually different, but I certainly don't think one size fits all. So trying to find intermediate subtypes, the sort of lumping and splitting, that give us a better idea about what might be different etiological courses, what might be sort of causing the concern, what is the best intervention matching, and what's the best predictor of an outcome, depends a lot on what kind of autism are we talking about. And so when I see families and I see learners, I'm rarely interested in the fact that it's autism. What I want to know is, like, what flavor? What are the concerns that the parent has? What are the concerns that the teachers have that's going to help this person maximize their potential? Whether it's autism or something else along that continuum is really not the essential question about what to do about it.
This is a sort of personalized medicine.
I think it starts to...
I said ABA is the original personalized
medicine. I'd say precision, sort of
precision. I've been saying that for years. Well, 3.
It's a good case for this, because if you go back to the nomothetic, if I give you 50 individuals with autism, and let's say I compare them to 50 neurotypical individuals, age, sex match, and then we take an average of both of those groups, you may or may not find differences between the neurotypical and the autism. Usually we do. But there's greater individual variability within the autism group than in the neurotypical group. And if we geek out for a second, there's a statistical proof called the ergodic theorem that has demonstrated that you can get an average of a normal distribution and not have any one single data point be the mean.
Most of us have seen that actually happen.
I think that's happening in autism.
Podcast listeners, look that one up. Because it happens all the time in biology too, that you have a bunch of cells and you made the measurement and every cell was different, and then you made an average. There was no cell. It was even close to the average.
I think one of the things, I don't remember if it's a current census or previous, but 2.3 was like the average number of children per household. It's a real statistic.
But there's no 0.3 nobody actually
kids.
Has 2.3 kids. Thank goodness.
Yeah.
Right.
It's a statistical artifact.
Yeah.
So we're just about out of time, but one more topic I wanted to touch on, which is sort of real-time intervention stuff. I guess it's important in the clinic, but it'd be really important to parents if they could see from some technology that you give them where this is going 5 minutes from now.
This is precisely what the work I'm going to share later today. So we did very briefly, a study across 4 psychiatric inpatient settings around the country. We had 70 individuals with autism, primarily minimally verbal, who engaged in high rates of aggression to self, other, and to property. And we put biosensors that could record cardiovascular, electrodermal, and motion from the individual with autism. And then we gave a mobile phone application to research assistants who were embedded in the clinical sites. And they were annotating for us the onset and the offset of tantrums, meltdowns, aggression to other people, self-injury that were naturally emitted. So they're not being evoked, and they're not necessarily the target of an intervention. Those behavioral observations are time synchronized with the sensor clock. And so we did 497 data collection sessions over 70 individuals. We have about 500 hours of biosensor data that has now been annotated with these behavioral onsets and offsets. And so then we did essentially data science, data mining, how much physiological data from the recent past is required to issue a prediction how far into the future at what level of precision or accuracy. These kinds of challenging behaviors are what most families will say really impacts quality of life. And that these behaviors, quote unquote, come out of the blue. And so by the time that they're aware that there's a problem, it's kind of crisis management. The best scenario would be that you could anticipate and predict the behavior and engage in primary prevention that obviates the need to engage in such an externalized behavior that you're going to now have people concerned about safety. And so what we essentially demonstrated across a variety of different machine learning models was our best performing classifier could predict the onset of these behaviors 3 minutes prior to their occurrence. That's when Leslie and I now start to get excited because that's enough time to do something.
Yeah.
And so most of today will be sort of that work, and some of our continuing since the time of that publication. But where it goes is, could we collect that data in real time, federate a behavioral observation with real-time streaming physiology, pre-process data in the cloud, run classifiers, and push notifications back down in real time that would give someone an alert about increased likelihood of an event occurring before it does, to then engage in just-in-time adaptive interventions as supervised by a clinician who has done functional analysis of that behavior and therapeutic probes to see what would be effective.
Yeah.
The idea is that you could transfer clinical knowledge to parents to act in a way that would be as though they're getting professional help without the dependency of a paraprofessional.
Yeah, in real time.
With them.
Yeah, and that I think is like the real power, because every single family, every single teacher, everybody I talk to, it comes out of nowhere, right? But it doesn't come out of nowhere for me. I can predict it's going to happen. So being able to predict, but just by knowing the past, reinforcers and doing that pattern analysis and doing that functional analysis, but taking that and transferring that knowledge to people who don't have to go to 7 years of training, so they know that to me is huge. That is going to, revolutionize safety and quality of life and impact for families.
Is that 3 minutes, a natural law or something? Is that Lyapunov exponent for human behavior or something like that? Could you extend it? I'm thinking like hurricane prediction.
Yeah.
It's a good point that you're raising. So, there's going to be an upper limit to how far back you can go before other things in the environment or biology intercede.
Yeah.
I mean, we do earthquake prediction, we do weather prediction, but it's never 100%, right? We have uncertainty. There are other variables that impact the causal chain.
Yeah. And our weather predictions go 10 days at most because you can't predict the weather.
Accuracy gets better as it gets closer, right?
The past is usually the best predictor of the future.
Correct.
And as you get closer to, it's called event time, you can be more certain. But there's a trade-off, right? The more certain I am, the less time you have to do something.
Right.
And so there's going to be a whole set of studies that we're going to have to think about uncertainty, and then what can you do within that window and how feasible is it? But, I want to get back to, there are not enough, we have an economy of scale problem. There are not enough Leslies in the world for the number of families who require it. So anything we can do from an assistive technology standpoint that raise consciousness, get parents thinking about cause-effect relations, that they have a role to play in an outcome, that is also collecting data by virtue of how that system functions, that can be fed back to the Leslies of the world to interpret it and guide it. I think we'll be able to learn more about the variations of autism. What are interventions that only a third party can provide versus empowering a family to transition those skills so they feel like they're more in control and keep their child safe. Yeah.
Well, thank you, Matthew.
Pleasure.
And Leslie,
Yeah,
both of
thank
you.
Charlie.
This has been a lot more practical than we normally are. And
Fantastic.
It's really good.
Thank you
So
for
really appreciate it.
helping us share the work.
Absolutely.
This has been Neuroscientist Talk Shop.